Hello, I am Dr. Shirish Gadgil. I'm the Chief of Division of Hematology and Oncology at Henry Ford Cancer Institute, Henry Ford Health System in Detroit, Michigan. Today I'm going to be discussing what testing should be done before frontline therapy for advanced non-small cell lung cancer. This slide shows the current recommendations by the NCCN for molecular testing in patients with advanced non-small cell lung cancer. For patients with adenocarcinoma, NCCN recommends testing for EGFR, ALK, ROS1, BRAF, MET, and RET translocations in addition to PD-L1 testing. For patients with squamous cell non-small cell lung cancer, PD-L1 testing is recommended. In addition, molecular testing is also recommended as in adenocarcinoma patients if the squamous cell patients are never smokers or the diagnosis is based on a small biopsy, since small biopsies may miss mixed histology tumors. It is important to note that NCCN recommends the testing for RET translocations as well as c-MET exon 14 skipping mutations, since FDA recently approved selpercatinib for advanced lung cancer patients with RET translocations, as well as approved capmatinib for metastatic non-small cell lung cancer with c-MET exon 14 skipping mutations. Several different tests can be performed to identify these gene alterations. However, data suggests that NGS testing may be the most cost-effective and may be associated with the fastest turnaround time. However, testing for gene alterations in advanced non-small cell lung cancer can be associated with certain challenges. In about 30% of the patients, the tumor tissue available for molecular analysis may be inadequate. If a repeat biopsy is attempted to obtain adequate tumor tissue, in 20% of the patients, such repeat biopsies may not be feasible. And even if a repeat biopsy is performed, in 25% of the patients, the tumor tissue obtained at the time of repeat biopsies may be inadequate for genomic analysis. A retrospective analysis of 1,200 patients from 4 different community practices showed that molecular analysis was performed only in 54% of advanced non-small cell lung cancer patients. These challenges could be mitigated to some extent by the use of liquid biopsies. Lail and colleagues found that addition of liquid biopsies to tissue testing could help detect gene alterations in 48% more patients than what can be done with tissue testing alone. It is important to note that sensitivity of liquid biopsies is only 70%. And so if a gene alteration is not detected in a liquid biopsies, it is imperative that tumor tissue is also tested for gene alterations. Due to the challenges of testing for molecular alterations in tumors of patients with advanced non-small cell lung cancer, and with the availability of data that combination of immunotherapy and chemotherapy provides survival advantage, several patients are initiated on chemotherapy and immunotherapy without appropriate molecular testing. However, it is important to note that the efficacy of immune checkpoint inhibitors in certain genetically altered non-small cell lung cancer patients may be limited. This is data from a French study that showed in patients with ALK translocation, checkpoint inhibitors had a response rate of 0%. Similarly, in patients with RET translocated non-small cell lung cancer patients, the response rate with immune checkpoint inhibitors was 6%, suggesting that initiating immune therapy in patients without defining the molecular alterations in patients' tumors may not be appropriate. In addition, there are concerns about using targeted therapy after immunotherapy. This is a retrospective analysis by investigators at Memorial Sloan Kettering that showed that in patients who were initiated on immunotherapy and subsequently were switched to osimertinib since they had EGFR mutations in their tumor, about 17% of these patients experienced significant immune-related toxicities. Though this is retrospective analysis, similar toxicity concerns have been noted with other targeted therapy. Thus, there are concerns about initiating targeted therapy after immunotherapy. In conclusion, testing for genetic alterations in PD-L1 before initiating frontline therapy in advanced non-small cell lung cancer patients is crucial. Though there are challenges in testing for molecular alterations, these can be mitigated by repeat biopsies as well as sending blood for circulating free DNA. NGS testing may be the most cost-effective and efficient method to identify genetic alterations that can be targeted for therapeutic benefit in the tumors of patients with advanced non-small cell lung cancer. And finally, since there are concerns about using targeted therapy after initiating immunotherapy, in patients where initiating systemic therapy is urgent and waiting for results of molecular analysis is not possible, one should consider starting such patients only on chemotherapy rather than on chemotherapy and immunotherapy or immunotherapy alone. Thank you very much for your attention.